We still have to do the diagnostic test. We still have to do the treatment options where, AI cannot replace humans just yet. So we're a long ways off from that. I think the skepticism is fair, but at this point, we need to use AI in sort of supplementing the care we are providing to the patients, not replacing it.
Well, then is AI going to have to start taking the Hippocratic Oath?
Yeah, maybe at some point when we have the robots managing patients, yeah, maybe.
In a world where AI is making us more productive as humans, can it also make us healthier? Today on AI in Action, we're going to get to the heart of it, literally. We'll explore the intersection of AI and medicine and take a look at how technology is changing the way doctors approach, treat, and analyze their patients, saving lives along the way. I am so lucky to be joined by Dr. Guru Kowlgi, cardiac electrophysiologist at the Mayo Clinic, and an expert in this intersection of medicine and AI. Welcome, Dr. Kowlgi.
Thank you so much, Albert. Pleasure to be here.
Yes, sir. We are really going to dig on in today. So let's start off with you. What's your background and what exactly is it that you do?
Yeah, so I'm a cardiac electrophysiologist. So the main part of my job is to see patients who have heart rhythm disorders, unfortunately, and then try to fix them with either medications or do procedures that we call ablations. So putting catheters inside their heart and finding the focus of these abnormal rhythms and getting rid of them. And then I also perform pacemaker implantations and defibrillator implants. And like you mentioned, I do find myself at the intersection of medical care and technology with AI. Was fortunate to do a master's in AI and healthcare. So I try to come up with these models that can help transform how we practice medicine by picking up diseases earlier than our traditional technology allows us to.
You mentioned intersection. So where did the intersection of AI and your career in medicine first start?
It started in 2019, so that's when I got into electrophysiology. So the path to becoming an electrophysiologist is you have to finish a medical school, do training in internal medicine, then go into cardiology, and then electrophysiology. So it's a long pathway. So in my final stage of training, I got introduced to a few people at Mayo Clinic who were pioneering some of these new AI models to screen for diseases early and pick up diseases early. So that's kind of what sparked that interest in me. As a kid, I grew up in a family of computer engineers and software, hardware engineers. So I always had that inclination. I'm the only physician in my family, so this was sort of coming back in a way of a lot of the stuff that I had grown up watching. Fun doing so.
That's so cool that you were able to take your own personal passion for medicine and for care and to somehow still infuse the family trait in there.
Yeah, absolutely. And I feel lucky doing that. And my dad was much happier when he found out I'm doing AI than when I became a doctor.
Let's talk about how AI plays an active role in your work today. How does a day in the life of you go with AI?
AI is at a stage in medicine where there are a few centers who are doing a lot of pioneering work and coming up with these models that help us detect diseases early. So Mayo Clinic is certainly at the forefront of that. So we've had models that have been in action for the last 4 or 5 years. So in a day-to-day workflow, what we have managed to create is this dashboard where if any patient gets an electrocardiogram, for example, it predicts risk of different diseases for that patient in front of us. So we use that in talking to the patient, sort of assessing their individual risk and deciding kind of treatment and testing to order to pick up these diseases early. So that's how it impacts our daily clinical practice. Then on the research side, there's always stuff that is, we're trying to push the boundaries and try to find new things. So I do a couple of days of research a week. I do clinical research as well as translational research involving animal models. So we have ways in which we can put catheters inside animals' hearts and find out these intracardiac signals that can detect disease or predict the location of these arrhythmia sites and use AI to detect those sites. So that's kind of how I'm using AI in research as well as clinical care.
Hold on, you just hit me with like quite a few amazing things. I want to unpack all of them. First off, I want to know what's the time frame that we're looking at. So like how quickly can AI help to make these assessments?
So in terms of the model developments, that takes a bit of time in terms of data curation. So if like a site like Mayo Clinic has well curated data over many years. So we are fortunate to have access to that data. The model creation itself takes a few hours once you have a plan in place and the data is all well managed. The tough part is once a model is created, how do you implement that into clinical practice? That takes months or sometimes years because we have to make sure the model is well validated. And then ideally, after the model is created, you want to test it out on a sample it hasn't seen before. So we validate that model and make sure it works well in a new population, for example. And once we know that that is the case, that's when we can sort of go to the FDA and say, oh, can we get an approval for this model and then use it for clinical practice? So that post development process takes a long time. Model creation itself would be maybe a matter of a few weeks.
Okay, so we're going to dig deeper into those models in a bit. But to start off, what kind of patients can this help and how?
Pretty much anyone. So I think we are using AI now, whether we like it or not, in every facet of our life. We wear smartwatches, use smartphones. They have a lot of AI algorithms built in. So essentially, it is going one step further and not only tackling the problem of scale, which is intuitive to people. So right now, where we are at with AI, with everyone using it, is the watch can look at your ECG, for example, and tell you have atrial fibrillation, which is a common arrhythmia. But going one step further is, what if the watch can look at a normal rhythm ECG and say, okay, you have a risk of AFib that's 5 times more than the general population in 5 years from now. So that's the kind of power AI has. So to answer your question, AI is ubiquitous. It's everywhere right now. I think the predictive power will get better over time as our processing power gets better and our data curation gets better. And eventually the challenge would be to have models that work well, to gain people's trust, that we can actually trust these models to predict and then act on those and treat patients accordingly.
But then how do you even start building this sort of a model? Because thinking about being able to look into the future and assess our risks going forward just seems so bizarre right now.
Great question. So essentially what we do is, let's say we have 30 years of data in a single center like Mayo Clinic. One example is the model for atrial fibrillation, which had over 600,000 patients ECGs studied. So we have access to patients who had atrial fibrillation diagnosed later, but say had 10 ECGs in normal rhythm before they had atrial fibrillation. So we can look at those ECGs in normal rhythm and train a deep learning model called convolutional neural network to predict those that have a higher risk of developing atrial fibrillation in the future. And essentially, we have access to those that stay in normal rhythm and those that eventually go on to having AFib. So just to back up a little bit, maybe for the audience who don't know what AFib is, so atrial fibrillation is an arrhythmia, which is the most common arrhythmia we treat. It's an irregular rhythm of the top chambers of the heart. AFib can cause symptoms of palpitation, shortness of breath, and that is annoying for patients. But a greater concern is the risk of stroke that accompanies AFib. So because the top chambers are beating irregularly, you can form blood clots that can go to the brain and cause a stroke. So these patients need to be treated with blood thinners. A lot of them get put on blood thinners once AFib is diagnosed. The problem is sometimes you don't pick up AFib until one of these complications have occurred. So unless you get an ECG at a time they're in AFib, you may never diagnose it. So that's where the use of AI comes in to pick up AFib in patients even before they have it.
So is this something that all of us should be somehow using, or would you just recommend this for patients that maybe have a history?
I think in this particular case, AFib, there are certain patients that are at higher risk than others. So definitely start out with those patients. But eventually, no patient is immune from it. And, it's one of those paradoxical conditions where athletes, for example, who are, at the pinnacle of, good health, also have risk factors for AFib because, endurance athletes, when they run marathons, their chamber sizes get bigger, and then the triggers for AFib are more common in these patients. So we see this in healthy patients as well. So no one is immune from it. But there are models for other conditions as well. So for weak heart pumps, there are models for valvular heart disease, for other systemic conditions. So I think eventually we'll be at a point where everyone will have access to these, and the big question is what to do with the access to that information.
You just mentioned a couple of other models outside of the AFib model. Can you break some of those down for us?
Yeah, so another big one is the model for low heart pump. So the heart is a muscle, so the bottom chambers of the heart help in pumping blood to the rest of the body. and the percentage of the blood that's get pumped out compared to what the heart receives is called the ejection fraction. So typically, the way to assess the ejection fraction is to do an ultrasound of the heart. It's a study that takes about 45 minutes to an hour to do. Multiple angles are needed. It's a person-dependent test, so it's resource intensive, and then someone else has to read it. A physician has to read the echo. So it takes a while to get this done. Now we have a model which can again just look at a 12-lead ECG, a safe, inexpensive, ubiquitous test that anyone can get at any point. Now you can get it with your Apple Watch. Once you get an ECG, that ECG can be trained or has been trained to detect or predict low ejection fraction. So essentially, you can come to the same diagnosis without going through an echo. What we ended up doing is doing a prospective trial where we gave access to this model to primary care physicians who were seeing these patients. And then those patients that triggered a higher risk of having a weak heart pump were sent for an echocardiogram to confirm. So the rates of picking up heart failure patients or low pump function patients shot up in the group that had access to the AI data. So that's one of the other models that's become really popular.
Let's zoom out from the heart for just a second, though, Dr. Kowlgi. Where else can AI modeling take us within medicine?
So within medicine, again, you can predict cancers, for example. So there are models that can look at imaging scans and pick up things that humans cannot see. And then I think we know at this point that computers process things much faster than humans can ever do so. Essentially, if you give it enough data points to train on, where you show normal scans, you show those with cancers or precancerous MRI of the brain, for example, the model can pick up things that we cannot even see. So that's another big avenue, like using this in imaging. Beyond imaging, you can use it in histology, like the tissue diagnosis when people get biopsies. The biopsies are seen under a microscope, and again, things that humans can see, the computer can see better. So we can pick up tumors and microtumors before we can even detect them with our own eyes.
Look, I know that you're probably an advocate for humans, but the way that you're talking right now, it sounds like the humans are subpar compared to the computer. So where do the humans live within this?
Yeah, and that is the skepticism that is, part of the industry and an important part of it, where the concern is, a lot of people actually not going into radiology fields anymore because they feel AI will take over those jobs. And the reality is, we are far from it. Yes, models can be trained to pick up diseases, but what makes medicine is the human piece to it. So this AI is always there to assist us, but then AI has to be in the background with humanity, humanism in the foreground to treat patients. And I'll give you an example. So when patients come in to Mayo Clinic and then someone comes in with a heart attack, you can have the best care, the best tents, the best treatment for their weak heart pump after. But I've had these experiences where I met patients after, and they remember the nurse or the nurse practitioner who met them in the emergency room, held their hand and said, "You're in the right place, we'll take care of you." They remember that over the 2 weeks in the ICU they spent with all of the technological advances that we had. It's just that human element is absolutely crucial to treat patients. So I don't think we can ever get away with that in cardiology or medicine in general. But from a more technical standpoint, I think we're at a point where AI helps supplement our care by picking up or raising our flags for the right patients early. And then we still have to do the diagnostic test. We still have to do the treatment options where, AI cannot replace humans just yet. So we're a long ways off from that. I think the skepticism is fair, but at this point, we need to use AI in sort of supplementing the care we are providing to the patients, not replacing it.
Well, then is AI going to have to start taking the Hippocratic Oath?
Yeah, maybe at some point when we have the robots managing patients, yeah, maybe.
I'm asking that because I'm thinking about trust, right? So, what kind of fear is there around trusting AI systems and even AI analysis when it comes to patients?
Yeah, a great question and an important question because the models are developed on a certain subset of patients, for example. Now, Mayo Clinic models are developed on patients who were seen at Mayo Clinic. And then one issue is that the patients we see here predominantly of one ethnic background. So we see like over 95% Caucasian patients, for example. Now, if you take that model and take it to some other country and apply it there where there's more black population, you cannot then use the same model over there because that model needs to be tweaked and then trained on the patient population that is more suitable to that area where you're applying it to. fortunately, we've done studies where we've taken some of our models and taken them, like the heart failure model, for example. One of my colleagues took that model and then and validated it in a sample in Africa for patients with peripartum cardiomyopathy. So these are patients who around pregnancy can get heart failure. And then she was able to pick up more patients who had cardiomyopathy just with an ECG alone than they did prior. So essentially, the models need to be validated. That's where the trust issues come in, that if it's used on a population it wasn't trained on. The next thing is people are used to practicing medicine a certain way, and they just don't want to change it. So if I tell them after they've been in practice for 25 years that, hey, I know you used to do echo and ECGs for these patients. Now this ECG will tell you what you need to know. They don't have to trust it right away, and they won't trust it right away. And thing is, what will help us achieve that trust are these trials where we show that yes, those models work, but then we've tried them out in the real world scenario, changed practice, and helped patient outcomes. So, trials are generally, the well conducted trials are blinded trials, are randomized controlled. So what happens is half the patients get subject to the AI treatment, AI diagnosis, for example, and the other half get standard of care. And then no one knows what is being used to treat them. And then we follow their outcomes. If we can show hard endpoints are better in the AI supplemented group, then that will buy trust from other physicians, other patients to say, okay, this actually helps in improving patient care.
Wow, because on one hand, it sounds like you're also talking about combating AI bias.
Yes, so AI bias is certainly there. I spoke a little bit about the ethical, ethnic differences in those biases, but also in general, AI tends to look at let's say a deep learning model will look at the data that's presented to it and fit the outcomes to that sample. And these models can be so complex over time that when you then apply that to a new population, they are overfit to their original population. So they don't work as well in a new sample. So the solution for that still is full disclosure, what was the training population like, and then validation. I think once we can do that, and then, prospective trials, ideally blinded, randomized with two arms, if we can do all of that, I think that will mitigate a lot of the biases that exist and then help with the trust factor as well.
All right, so I feel like you've solved a couple of main issues and concerns right there for me. But also, let's keep on playing with this. Where else can things go wrong, doctor? What are some of the other ethical dilemmas that do need to be addressed?
I think at this point we have a lot of models that are being created, but not enough that are being validated and then translated to clinical practice. So I think the data management is a big deal. So let's say we want to create a model that works everywhere. You want to share data, right? So you want to be able to work with multiple institutions and create models that are applicable everywhere. But therein lies the problem of privacy, patient confidentiality, and then patients don't want to share their data. And if they do share their data with other institutions, and who owns the data? So all of these questions, ethical questions, exist. I'll give you one extreme example. Was a model that was used to detect tumors in the brain. They were using head CTs to do that, so CAT scans, and then they had about 500 patients or so, and because the head CT contained details of the skull and the facial structure, the investigators were able to find Facebook or online images of patients from the CT. They trained the CT images to find the actual people. So the privacy is all out of the window at that point, right? So that is one extreme example of how much data that's out there that we didn't even fathom exists, that machines can glean into and then find out. So I think the biggest concern is data privacy. There are a lot of companies now helping with that, and then we touched upon some of the other issues of how the models are created, how can we be more diverse in model selection, and then also validate them.
But then how do you train the next generation of physicians to adopt this new technology? You seem to be on the forefront of it.
I was fortunate because at the time I was coming on staff, that there's this new master's program in AI through Mayo Clinic College of Biomedical Sciences. And then I was like, let me just do this. I have some time as an early career, and things worked out well. But this is a big question because our current curriculum in medical schools don't prioritize AI training. And whether we like it or not, as I mentioned, AI is here to stay. It is part of our lives now. And then even if a physician does not want to practice AI or develop AI models, they have to be able to consume the data. So when we see patients, when we look at trials, all of us are equipped to read a trial and understand how it was done and see if it is applicable to the patient in front of us. The same kind of training needs to happen for AI models. So when a patient comes in next time and says, hey, there was this model that was developed at Duke, and I'm coming from there, and I applied that to my ECG, and it tells me I have a 50% chance of having this arrhythmia in the next year. What should I do? I should be able to look at the model, look at my patient, and tell them, okay, is this model applicable to that patient in front of me? And to be able to consume the data, you need some kind of training. The next step is people who are translators. So people who can not only consume the data, but can break it down to an engineer and say, okay, this is a problem that is unsolved. Can you look at this data and come up with a new model? So they're sort of the middlemen between physicians who are consuming the data and then developers who are eventually creating these models, who are engineers. So it's a three-tier system. I think we need to create consumers. That's everyone in medicine. Translators are those that want to go to the next step and then want to learn how to code, but don't code for a living. Like I would consider myself a translator, where my primary job is still clinical medicine, but I can speak the language enough where I can break it down to the engineers and help create a new model. And then there are the engineers who basically are the software folks who are coding and then develop these models as a full-time job. To train physicians, we need to have some kind of curriculum in medical school where it's like journal clubs, for example, where they can look at AI papers and then break them down. And then there's a lot of online curriculum as well. So YouTube, I learned a lot from YouTube in terms of just understanding data science. There are certain third-party applications where you can sign up and get training from them as well. And then there are master's programs, there are certificate programs that are available that interested people can sign up for. It's a bit of a time investment, but I think it's a worthwhile time investment, especially for those who want to go to the next level.
Well, it really sounds like the landscape is changing, but there are a ton of new opportunities in medicine that are also developing. Where should someone who's just entering the field be looking?
I think the first thing is to just look at the data that is out there and then read the papers and see if this is something that they would want to be involved in a more direct fashion. And if so, it just depends on where they are at. So speak to the providers in that school, in that institution, who have any interest in AI, and then get connected to programs either within that institution ideally, or something that's nearby, or an online course, and get started early. There are a lot of free resources online. I mentioned YouTube, but there are a lot of other resources as well, where you can get that initial interest generated. You can realize if this is something you want to do or not, and if that interest is there, if this is something you want to pursue further, then I would strongly recommend a formal program, either a certificate or a master's program after that.
So, is there a professorship in your future, Dr. Kowlgi?
Well, I mean, I think I still love clinical medicine way too much to sort of leave that, but I would like to keep doing AI on the side and help develop models, and then do some training in this as well.
Gotcha. Okay, well, then what are you most excited about moving forward? What's the future of AI in medicine?
The future of AI it lies in predicting diseases before they occur. So I sort of look at it as a three-stage problem. The first stage is, what AI solves is the problem of scale. So just looking at something that humans are looking at and just doing it at a a much faster pace than we do. For example, when we get an ECG, you get an automated diagnosis that the computer comes up with. So that's a problem of scale. So I can read maybe 500 ECGs a day. A computer can read 5,000 ECGs a day and do the same thing but faster. Going beyond that is picking up disease early, which is where we are at right now. So essentially, you have someone who has a risk factor for atrial fibrillation, heart failure, and it picks it up in a normal rhythm ECG before it happens. And that is something we've sort of checked that box. What I'm excited about in the future is how AI models can predict things that have not even happened, that there are no signs at this point. One example would be someone who has a defibrillator for primary prevention. So these are patients who have some risk factors but never have had a cardiac arrest. We put a defibrillator in them because we are worried that at some point they might have it, and it could be for a genetic condition, it could be for a weak heart pump. But we have models that can look at device tracing. So they have a lead in the right bottom chamber of the heart. It has normal tracings, and it can detect an arrhythmia episode, a cardiac arrest episode, 30 minutes before it happens. So imagine the possibilities there. So if that is validated and that is found to be true, Then, before someone has a cardiac arrest, there could be an automated call to EMS. That EMS arrives at their place before they actually have a cardiac arrest. The hospitals can be alerted, and then we can essentially take care of the patient before anything happens and prevent these things from happening. Another fascinating avenue is the use of voice. So, you can essentially train models to hear your voice and identify the different frequencies and find out if you're having a heart attack or not, or you have a risk of heart attack in the future. So a future looks like this, where you'll be calling the provider or calling the nurse in the clinic, and they will diagnose you before they even see you because they can pick up diseases on the through your voice. People can be triaged in the emergency room faster. So you come in, you read a line, and then they'll be like, okay, you're a high risk, you're a low risk, you'll be seen first. That kind of possibility is not that far out in the future. I'd say in the next 5 years, we have technology that will be able to do that.
Oh, I was hoping you were going to say like fall 2025.
The models are there. I think till we can all trust them and believe them and implement them, it'll take a few years.
Now, it's time to make a prediction. What's one specific AI trend or use case that's going to get more attention in the next year?
I do think out of the ones I mentioned, the voice thing is very popular. I think that is something that will go from the papers where it is right now to human use very, very quick. And it's easy to use. You can use your iPhone for that. You can have apps which record your voice and tell you what's going on. So I think that'll be the big one.
Well, from your POV, then, what's the biggest misconception about AI?
Well, the one thing that we touched upon was that AI is replacing human jobs in medicine or in general. I think that's a big, big misconception. It's just not going to happen anytime soon, or hopefully never, because there'll always be things that humans can do from an emotional standpoint that AI just cannot do at this point. And then this goes beyond the technical diagnosis. So I think that is one myth, and I really like to hammer that in to people. It is a very different field. Medicine is a different field than technology, than SpaceX or Tesla, because this is where emotions play a vital role in patients getting better. So yes, AI can replace human jobs in other sectors, but not in medicine.
Well, last question. As a heart doctor, what's your advice to our audience on general heart health?
Stay active, move a lot, exercise, eat healthy, and then by healthy I mean just a balanced diet, high protein, as low carbs and fats, and in general just enjoy life, meditate, sleep well. The sleep factor I'm still working on, so I cannot preach what I don't practice. But overall, I try to be active and stay healthy. So it's easy to keep your heart healthy. So just do these 3, 4 things, and then you'll be in good shape.
Dr. Kowlgi, thank you so much again for your time. And also to those of you at home, thank you for listening. Stay tuned here for more. And you heard what the doctor said, stay active.